Good evening, everyone. I hope you all are doing great. My name is Janet Davis, and I am an Associate Director in Plan II Honors, and I'm also a professor in the Department of American Studies and the Department of History here at UT. And I'm so glad to welcome all of you here this evening. And we are going to have a great dynamic set of presentations. The students have worked really hard all through their year of thesis research and writing, and this is a really joyous occasion. So even though we all encompass rectangular boxes scattered all over the place on Zoom, there is a really great, good sense of goodwill and a lot of fun here. So I'm delighted to welcome you. So I want to go through just a couple of rules that will kind of animate how we handle things this evening. Okay, so first of all, we're gonna, if you can, please remain muted because each speaker will need to have the floor. And secondly, when you have questions for the speakers during the question and answer portion of each person's presentation, I ask that you write your questions and put them in the chat, okay? So that's how we'll handle things. And then what I'll do is I will read your questions to the presenter and they will then respond. So that's how we've done it in the first section. It was great, and I think it'll work really well here as well. So one other thing, just to let you know, that each person will be speaking for 8 minutes. And if a speaker goes a little longer, I will, trying not to be rude, but I will just let them know that time is up and they'll need to wrap things up. And then we'll move into the Q&A portion, which is also approximately 8 minutes long. And that's when, you can feel free to type in your questions in the chat and we'll make sure to have each presenter address your questions. So each person will have presentation time and then Q&A time, and then we will move forward with each subsequent presenter. All right, so without further ado, I am pleased to announce our first presenter this evening is Banks Blackwell. Banks's thesis is entitled An Unimaginable Burden, a synopsis of the current and future state of healthcare. Banks's supervisor is Professor of Management, James Miller. And I am delighted to welcome Banks. It is your floor, and we look forward to your presentation.
Awesome, guys. Well, thanks so much for being here. Janet, can I just get a thumbs up if you can hear me nice and clear? Perfect. I'm going to share my screen really quickly with you guys. So as she said, my name is Banks Blackwell. I'm a Plan II Honors and Finance student here at Texas. The title of the thesis is An Unimaginable Burden, a synopsis of the current and future state of healthcare. And now really quickly, I want to show you guys a video on why I decided to attack this specific topic.
It can't say no, it's corrupt, it's inefficient, it's slow.
You push for single-payer healthcare right here in the U.S.
Is there a price for that?
Yes.
Jeez, $100? $2.5
grand.
Man, so if you're poor, you're dead.
Medical expenses are the #1 reason why people declare bankruptcy in the U.S.
It's been very much misreported that we failed with healthcare. We haven't failed. We're negotiating, and we continue to negotiate.
Bureaucrats in control of our healthcare.
We can't afford one-size-fits-all plan.
Obamacare is wrong for America.
However,
Obviously, healthcare today is extremely complex, and there's a lot of different things happening. Let's see here. Healthcare today is slow, it's complex, it's reactive, not proactive, it's expensive, it's a fee-for-service model, not value. It's focused on profits, not the patients. It has misaligned incentives, it's inefficient, but most of all, it's American. And so the goal of this paper is to first give the reader an idea of what is encompassed within this complex system we have today. The next step is then to try and tell the reader, okay, well, why have we decided to go with this system in America specifically. And then the final part is to say, where's healthcare headed next? And so what I mean when I say that healthcare is an inefficient system is first that as a percentage of GDP and as total per capita spending, we spend way more than any comparative country. This graph here on the left shows that in dollars, adjusted for the differences in the cost of living, the US outspends all other countries dramatically in out-of-pocket spending, private spending, and public spending put together. And during the research, I even adjusted for demographics because we know that an older population would spend more money. We then adjusted for utilization as well. So if US citizens just used a lot of healthcare products, that might explain this cost. And then we adjusted for wealth, meaning that because the US is so wealthy, maybe they're just spending because they have that extra income. When we adjusted for all of these things though, the US still had an incredibly high rate of spending that was higher than any other country within the OECD or other comparables. And so it's inefficient because even with this really high level of spending, we're getting lower health outcomes. Although I could have given you hundreds of data points, I want to just outline two small ones here. The one on the left shows that US male life expectancy at birth relative to 21 other fairly comparable countries is significantly lower and has been decreasing in comparison over time. On the right, you see the mortality for non-communicable diseases in 17 peer countries. Once again, the US has very low health outcomes, even though we're spending a lot of money. So obviously we see a problem here. But then I wanted to look at healthcare within a global perspective to start to gain an understanding of why this is happening. So really quickly, in Germany, they run a system called the Bismarck model. That's because that model has private insurers and private payers, but the government intervenes to set price points, and it also requires all of the insurance companies to provide insurance at cost. So no profits, and any profit they make has to be reinvested to reduce deductibles. They created that system because the values of the German people are things like unification, vigorous competition, and applied Christianity. And all of those systems are seen within that Bismarck model. In Canada, for example, they have the national health insurance model. What that means is that Canada is the payer for all healthcare, but the providers are they're private. But something that's really interesting about the Canadian system is that you can't go and buy a higher level of care than what is considered the baseline level of care. And that's because Canadians value fairness, accessibility, and inclusion. So once again, the values drive the model. And then in the UK, which is the third majorly adopted system, that's what we would consider socialized medicine because both the payer and the provider are government entities. It's called the NHS in the UK. And this system was created based on the values of mutual respect, equal opportunity, and aid in the redistribution of wealth. After World War II, this was really important as the UK saw a lot of inequality in the area. And so what does this mean for us in the United States? Well, we actually have a little bit of all of these systems. Our open market system that we use when you're under the age of 65 or not considered to be under the national FPL is the Bismarck model. And that's because you have private payers and private insurers. And then you have Medicare and Medicaid. In that system, the US is the payer and they pay to private groups. So that's the national health insurance model within the United States. And then the way we provide healthcare for US veterans and Native Americans, that's the Beveridge model, because in that system, both the payer and the provider are government entities. And then finally, our uninsured population shows what an out-of-pocket healthcare plan looks like, because all those people have to pay any cost that they receive out of their pocket. And so what does this system show? It shows that the values of the United States, we value things like freedom of choice, specialization, innovation, and achievement. And you can see that all over our system. We have some of the best specialists in cancer treatments in the world, and our open market system allows people to choose what they want. And in that way, we have one of the best systems when it comes to endorsing the values of people. So when I looked at this, I realized, okay, well, healthcare is driven by a country's values. I had to address, well, where's healthcare headed next? Well, this chart on the left is by the Bipartisan Policy Center, which is a group of senators on the left and the right and the center. And they went out and they polled and they said, what do the US citizens want when it comes to healthcare reform? And what they found is that people do not want to repeal or replace the ACA, which is what we currently work on today. But they also don't want to transform to a Medicare for all style single payer healthcare system. Both of those are kind of considered the polarized changes in healthcare. Instead, people want to improve the current healthcare system through the bounds in which it already exists. So that's really important when I decided, where's healthcare headed? And so we need to, one, address healthcare within its current structure. Things like Medicare Advantage are doing that with new capitated models. The next step that we think is going to be really impactful in the next couple of years is the government has already been starting to endorse healthier markets through transparency policies. That's because right now it's really hard to understand how much healthcare costs, how much a co-payment is going to be, what's the full care cycle cost. And so through legislation that really encompasses transparency, we think a lot of change is going to happen in that field specifically. And finally, we think that the government is starting to endorse value-based contracts. And that's a really complicated topic because right now, an insurance model pays a provider based on volume. And so the more people you see, the more you get paid. But what a transition that's currently happening, but in the early stages, is value-based contracts. And what that means is you're paying for healthy outcomes, not for volume. So it's becoming more about healthy patients than the volume of patients you're seeing. All of that has led to what I believe is a really good definition of where the healthcare system is at, why we are where we are today, and where we're going to see change in the next coming years. Thank you guys, and I would love to take any of your questions.
Great. Thank you so much, Banks. You've raised so many important issues here, and this is fascinating. So I'm just going to get started by asking about the research or the think tank that is bipartisan, nonpartisan in its conclusions about the majority wanting to improve current system rather than overthrowing it. And I wanted to hear more about some of their research and who they interviewed and just more of that, because it's really interesting. And thinking about value transparency and value-based contracts or outcomes and all these issues that you've raised that are so important.
Absolutely. So, when I was doing the research, I always hate turning in a paper or, maybe a business model that's not tangible, something that can actually be implemented. And so when I found this and they raised the idea, hey, listen, the people don't even want these polarized changes.
Mm-hmm.
They really want to see change come from within the bounds of what already exists. And so that really guided the rest of my research in saying, okay, what is healthcare going to look like in the next couple of years? And so some things they were looking at were, first off, drug pricing is a huge issue in the United States. Sadly, because of the depth of other topics within the paper, I don't address that, but that was important to them. Yeah. And then these value-based contracts. It's a really weird word and a weird topic, but it really is the future of healthcare.
Interesting. Okay, there's a lot to talk about here. We do have a question here in the chat from Marilyn Felkner, and here it is. You mentioned adjustments based on age, income, and other variables. What was the source of your data, and what analysis did you do yourself?
Awesome. That's a great question. So there's several different data points. I read a lot of scholarly articles, and then I had a lot of books that I was reading. And so Yui Reinhardt, who is sadly not with us anymore, but a pretty well-known healthcare author. So he did the thoughts on adjusting percentage of GDP. And then demographics came from two other books where they said, here, look, obviously the US population compared to these other countries is not even as close to as old as their populations are. So that's where that research comes from. And then with the wealth, we adjusted the OECD data based on as a percentage of GDP. And brought it down. And so that gave us a really good idea that even when we adjusted for all of these, the US is still spending a lot more than other countries.
Interesting. So we have another question from Prakash Jayakumar, and it is this: to thank you first for your presentation, and this is the next part of it. You stated, quote, healthcare in the US is driven by people's values. Do you think the values of Americans have changed over recent years since the introduction of Obamacare, and especially this year since the COVID-19 crisis, and how millions of Americans are potentially further impacted since the pandemic? Incredibly timely question.
That's definitely a very, very timely question. When I did the research, it was interesting. There's some of the things that I looked at. There was some research on over time, what if people thought about a single payer system in the United States? Believe it or not, in 2004, it had 58% adoption with, well, not single payer, but people believing that the federal government needed to provide healthcare to all US citizens in one way or another. So in 2004, that held a majority. In 2014, that then flipped actually to hold a minority, where people did not believe that the federal government had this obligation. And I think I would be wrong to tell you, where US sentiment is within that question. But I do think that, COVID has shown us that there are some serious, that we have great coverage of care when it comes to, we can implement all these COVID beds and these ventilators, but at the same time, it's tiered healthcare. Based on your income level, you get a very different amount of care. And so that will be a defining factor, I think, in the future.
Mm-hmm. For sure. Well, I have another follow-up question, and it relates to thinking about, healthcare is a monolithic label for a lot of diversity within it. And so I'm curious about what your research, if at all, dealing with mental health care, and how, just to consider mental health care as part of medical health care. And if you find differences in the ways in which the data points to coverage and care.
Mm-hmm. So one of the biggest issues within the United States is that the way we write contracts and the way the system's set up is we don't incentivize preventative care. When I say preventative care, an important part of preventative care is that, helping people, with that kind of medicine. I didn't research necessarily the spending we do in that sector, but I did a lot of research on, how impactful is social expenditures like that kind of healthcare on healthcare outcomes. And, as predictably as I'm about to say, there is a giant correlation. You get much better health outcomes in population health metrics when you spend more on social spending like that kind of care.
Right, for sure. Great. So we do have another question in the chat. This also comes from Marilyn Faulkner. And the question is this: what is the difference in private pay and out-of-pocket pay? Good question.
Okay, absolutely. So your government pays your Medicare and Medicaid. They're the payers in that situation. And then for private, think about if you had United Healthcare. They are paying for your healthcare in that scenario. And out-of-pocket pay, so uninsured people, if they go and have a surgery, that's all going to be out of pocket. But your co-payments and deductibles would also be considered out of pocket, because that's directly coming from you, not as a prepayment, but a prepayment post-service. Mm-hmm. Does that answer your question? Awesome.
Great, thank you. We have another question in the chat from Katie O'Donnell. How will the shift to a values-based model impact the cost of healthcare? Is there any research conducted related to this shift in healthcare policy over the next few years? You may have just addressed this with your answer about preventative care, but this provides a point for elaboration.
Absolutely. So, something that I really think perfectly shows that this preventative care can be effective and this value-based contracting is really going to create an impact is Medicare Advantage plans. And so Medicare Advantage plans get basically the average cost of a Medicare patient as a capitated rate. So they get prepaid for all the services they provide, and then they have to attract customers. Well, some of these plans are providing value-based medicine that creates quality, comfort, and care for their patients. And then anything left over between what they provide and what they were paid is revenue, basically, well, as profit. And so these models have seen a drastic increase in adoption in the last couple of years. From about 2005, about 1/3 of Medicare patients are now on Medicare Advantage, which are private providers of healthcare working in that value care field. I think that really signals that there's something here and something that's going to gain traction in the coming years.
Very interesting. Great. Any other questions before we move on? Okay, well, I would like to offer a round of applause for Banks's presentation. Thank you so much. That was fascinating and extremely timely. Really great. Thank you. So we are going to move on to our next presenter, who is Emily Curl. And Emily's thesis is entitled Mindfulness Intervention for Parents of Children with Autism. Emily's supervisor is Professor of Special Education, Lauren Hampton. The floor is yours, Emily.
Hi, everybody. Thank you so much, Dr. Davis. I'm just going to share my screen really quickly. Okay. Hi, my name is Emily Curl, and for my thesis project, I conducted a mindfulness intervention for parents of children with autism. First, I want to talk about why I chose this demographic of parents for my study. Parents of children with autism have enormous stressors in their day-to-day life. It is said that when you meet a child with autism, you've met only one child with autism. That means that every parent of a child with autism has a set of circumstances that are completely unique to them. Parents of children with autism report higher levels of stress, depression, and anxiety than parents of neurotypical children. They also report greater pessimism about the future and a lower quality of life. According to Zeidman, Zeit, and colleagues, just as children with autism experience a complex range of social, emotional, and behavioral difficulties, families who fall on the autism spectrum are often troubled by economic, social, and psychological problems above and beyond those with typically developing children. I chose mindfulness because it has been studied to help other people mitigate their stress levels, yet there were very little studies involving parents of children with autism. Next, I just want to give some quick definitions of mindfulness and self-compassion. These definitions were created by doctors Kristen Neff and Christopher Germer, whose program we used for the intervention. So mindfulness is the ability to pay attention to any experience, positive, negative, or neutral, with equanimity. And self-compassion is actively soothing oneself when painful experiences arise and remembering that such experiences are part of being human. My hypothesis for this experiment was that parents who attended the Mindful Self-Compassion workshop would experience less stress and higher reports of mindfulness, self-compassion, and self-efficacy, which may impact the parent's ability to implement parent-mediated interventions with their child and impact their child's overall progress when compared to the control group. For my methods, we recruited our participants and we randomly split them into control and workshop groups. Both the control and the workshop group were to take surveys before the mindfulness session began and after the last session was complete. These surveys were the Early Intervention Parent Self-Efficacy Scale, the Broad Autism Phenotype Questionnaire, which was only taken at baseline, the Parent Stress Index Form, the Freeburg Mindfulness Inventory, and a self-compassion scale. The intervention group was to participate in the Mindfulness Intervention Workshop. The workshop was 1 hour and 15 minutes once a week for 3 weeks. The workshop was conducted virtually through a video conferencing software due to safety measures associated with the COVID-19 pandemic. Using a remote medium opened up the study to parents of children with autism from cities other than Austin, Texas, and we recruited a lot of parents also from Houston, Texas. The virtual workshop also enabled participants to watch the workshop asynchronously at another time. 3 of the participants opted to watch asynchronously at least one of the sessions, and all of the parents were able to watch the sessions during the same week in which it was hosted to be able to keep up with the material. Mindfulness and self-compassion are exceptionally broad topics, and it can be daunting for someone who is hoping to learn how to implement some of these practices into their life. This pilot study was meant to be just a beginner's course into mindfulness and self-compassion. The teacher of the mindfulness workshop in this study is a certified mindful self-compassion coach and created an introductory curriculum to maximize information given to the participants in the workshop during this short pilot study. Based on her expertise in hosting similar workshops for other parents who are at risk for experiencing high levels of stress, such as chronic illness, she selected core features of the Mindful Self-Compassion program to directly address this concern for this population. One exercise included, how would I treat a friend, in which the participant compared how they would treat a friend who's going through a difficult time to how they treat themselves. They also learned things such as self-compassion breaks, gratitude practices, and different grounding meditations throughout the sessions. After the session, we had a 1 hour-long focus group where we asked questions regarding mindfulness, the workshop, and other questions specific to parents of children with autism. Some of the results for the study were surprising. The current study only confirmed our hypothesis that parents who attended the Mindful Self-Compassion workshop would experience less stress and higher reports of mindfulness, self-compassion, and self-efficacy in part. As hypothesized, the results from the self-compassion scale and the mindfulness scale showed that there were large differences between the control and workshop participants, as well as changes from pre to post test within the intervention group. The parenting self-efficacy scale showed no meaningful differences between the control and workshop group, nor within the workshop group. However, the focus group told a different story about parenting self-efficacy. During the focus group, parents stated that they felt more at ease with themselves and with their family members. Parents stated that the workshop has helped them to treat themselves better and helps them take a step back and realize that things are going well and that they are able to take care of themselves while working on things that are still in progress. Many parents expressed that mindfulness has helped them with self-patience and self-kindness when it comes to parenting their children. And then interestingly, as seen on the table in the slideshow, it shows on the PSI total, it shows that parenting stress levels increased during the duration of the workshop. But we predict that this might be due to outside factors such as the COVID-19 pandemic, along with the fact that this study was being conducted right when school was starting back up from summer break. Lastly, I want to discuss some adaptations and implications. So for adaptations, beginning the workshop with icebreakers and having longer introductions can make online workshops more personalized. It could also improve parent engagement and encourage growth of a community with one another, which can also improve stress levels, mindfulness, and self-compassion. This study was feasible and reasonable to conduct in a virtual format. Surprisingly, parents loved the virtual format. In the focus groups, they discussed the benefits to online mindfulness classes, which included reduced or no travel time and no need to hire childcare. Hypothetically, they were able to log into the sessions from anywhere. And those who were unable to attend the live workshop were still able to watch the lessons asynchronously. It was feasible to conduct because we had a highly trained mindful self-compassion coach who has experience delivering this type of intervention in a virtual format. The participants also enjoyed the lessons that our instructor chose to teach. Parents of children with autism have increased stress levels and may need an outlet to help eliminate some of the stressors of their day-to-day life. The mindfulness and self-compassion questionnaires showed meaningful improvements in parents who were involved in the intervention group of this study. This mindfulness intervention for parents of children with autism is a feasible and acceptable way to help increase mindfulness and self-compassion in parents who have children with autism. Thank you so much, and I'll take any questions.
Great, thank you so much, Emily. That was really fascinating. I was furiously writing notes the whole time because it was so engaging and so interesting. Wow, so people are going to be putting some questions in the chat, which I will get to as soon as they emerge. And I wanted to start off by asking you, how were the participants, how did they find out about this program and the surveying?
So we recruited our participants through a lot of different outlets. We actually had a really difficult time with recruitment. We don't know if it was due to like COVID or just the timing, or if people just genuinely were like, this isn't for me. But we recruited through Building Blocks in Austin, which is an organization for autism. Yeah. We recruited through some developmental pediatricians. We recruited through the Jewish Family Services in Houston. And I also went on Facebook and found some autism Facebook groups, parents of children with autism, and tried to recruit through there. But we did have a difficult time recruiting people.
Sure, sure. Well, I was also really struck by your comment about the online format, being so positive for people. And I'm just imagining what that must be like, with people with such busy, complicated lives, and the act of not having to travel, not having to get childcare, when you're already living a really, complicated life, that was really amenable to, their own, what they had going on in their lives. So to be able to do this at home. So I'm really interested in that.
It's really amazing. I was really surprised too that we received so much positive feedback, even with the technical glitches. And, not all parents are technically savvy. I know I'm not very technically savvy. And so even with that, though, we had a very, very positive response. The parents really, really loved the fact that they could do something for themselves while sitting in their house, that they didn't have to go anywhere to do anything. They liked even the privacy of it. I think there were definitely some downsides that were expressed, like a little bit of a lack of community, and the parents weren't able to exchange phone numbers with each other, which was, I think, frustrating for some parents. But other than that, I mean, it was overwhelmingly positive. Yeah.
Yeah. Yeah. Would you say that in a pre-pandemic world, have there been, a lot of robust support systems for parents of autistic children in terms of meeting up and, getting together?
I'm not 100% sure, but I think that there might be. I think that especially in studies like this, where parents, like we were supposed to, before the pandemic, we were planning on doing a 4-hour session in-house at a location in Austin. Wow. But that would have, that would have been awesome. But it was really interesting to see that we could open this up to other people other than people in Austin, Texas. We had a lot of people from Houston who were Zooming in, and they would not have been able to join if it weren't for the online format.
Definitely. What would you say in your research has surprised you the most? Every research project is a journey, and there's always something that's like, oh my goodness, I never would have thought of this.
I was really surprised that the stress levels increased. Yeah. I was, and again, it wasn't a very long study. It was just a very short pilot study. But I was really pretty shocked that even with the, with everything going on, I was still pretty shocked that the stress levels increased. I would have thought that they would have decreased because everything else seemed to, go the way that we kind of thought it was going to go for the study.
Right. And you made a really good point about the coincidence of school starting and, other just really stressful times, other mitigating factors that could really increase stress as well. So we definitely have got some good questions going in the chat now, and I'm going to turn to those. Here is a question from Katie O'Donnell, who applauds your research and wanted to ask, can you speak more to the timetable of the workshops? And how did the outcomes indicate how the parents who participated would be able to continue mindfulness practices after the workshops? This is something I definitely wondered about as well.
Hold on, I need to have the question open so that I can make sure to answer.
I can repeat it too. Do you have it?
Yes.
Great.
The timetable of the workshops. So the workshop started with a grounding meditation. Basically, it opened up, there were loving kindness meditations, there was a listening meditation, and so it opened up with that. And then we started doing the activities. So we did, one of the favorite activities was how would I treat a friend? So that's how I explained when you basically think of a difficult scenario that you've been in, and you think to yourself, how would I treat a friend if they were in this scenario, versus how I treat themselves. And most of the parents said, oh, I would treat a friend, with kindness and gentle. And then I would treat normally when it happens to myself, I treat myself, I'm very harsh with myself and hard on myself and things like that.
So interesting. Wow. Keep going. Sorry.
The outcomes, how did the outcomes indicate how the parents who participated would be able to continue? So we actually provided the parents with incentives. So we gave them a booklet. I wish I had it. I would show you a mindful self-compassion workbook that they can work on and continue to, brush up after the workshop was over. But basically it's really up to them. We had a lot of parents who were really, really engaged and really wanted to learn the material. So I'm sure that they're practicing still.
That's great. Wonderful. So we have another question from S. Curl, and it is, did the parent participants express any specific techniques that were most effective for them personally? And any techniques that they will be able to continue practicing on their own? So a nice compliment to Katie O'Donnell's question.
Yeah, so like I said, they loved the how would I treat a friend? And there was also one grounding meditation called Soles of the Feet that they really liked, where you really focus on the soles of your feet and how your feet are feeling, like, I guess the bottom of your feet are feeling. That one. There was also one called Stop, where you basically just like pause what you're doing, take some deep breaths, and then start doing what you're doing again. And that was really helpful for mindfulness.
Yeah. Oh, amazing. Wow. Well, I'm going to just give anyone else a chance to ask any other questions. I'll just pause for a moment. What are your future plans? I wanted to ask you that.
So I need a break from academics, but then I would love to pursue a PhD in psychology.
Great. Wonderful. Yeah. And it's a perfect project for preparing you for that future path. That's excellent. Yeah. So we do have another question from Marilyn Felkner, and it is, did you collect any data on where children were on the autism spectrum to determine what impact that had on the parents' response? Really great question.
We did not. We didn't ask where on the autism spectrum parents were.
Mm-hmm. Okay. Yeah. Well, fascinating, really fascinating research. And great. Another question from Prakash Jayakumar. Nice work, plaudits. There were lots of different elements to each intervention. Do you think that some of these could be particularly of benefit from technological support?
I don't understand the question. Sorry.
Actually, if Dr. Jayakumar wants to unmute or just write it in the chat, either way is fine. If you want, we did that in the last session where we had some actual dialogue. I guess we're breaking rules a little bit, but either way, or just further elaboration in the chat as well. So, great. Okay, well, I think that, maybe it was a question of relating to, the multifaceted nature of these, different interventions, and if technological intervention was, appropriate for each of these different these different elements. And I think we are dealing with a problem of a blocked mic. So unfortunately, Dr. Jayakumar cannot do that, can't access it. But what we can, I guess we will probably just move on in a moment. But if you wanted to address that, we'll move on to our last speaker.
I think this intervention can definitely be used technologically. I hope I'm answering the question correctly. We were thinking about for future implications in practice. And so while we were thinking maybe while parents have their children in therapy, they could do a Zoom session and just do a 5-minute mindfulness Zoom session while they're sitting in the waiting room. So that could be a future application for this study.
Great. Okay. Wonderful. Okay. So this is excellent. And really delighted with your research. It's super exciting and incredibly useful to so many people. And so just to give you a round of applause, great job. And we are going to move to our last speaker, who is Ray Kitziger. And Ray's thesis is entitled Integrated Healthcare Delivery. And Ray's thesis supervisor is Professor of Surgery and Perioperative Care at Dell Medical School, Professor Prakash Jayakumar. The floor is yours, Ray.
Thank you. Can you hear me all right?
Yes.
Awesome. Let me share my screen and get that PowerPoint up. Okay. How's it look? All good. All right. Let's get into it. So my presentation is entitled Integrated Healthcare Delivery. And as you mentioned, I was supervised by Dr. Prakash Jayakumar, and my second reader was Dr. David Ring. And this presentation is going to kind of have 3 parts. First, we're going to talk about why we need something like integrated healthcare delivery, which luckily Banks talked about quite a bit, so I'll be able to go through that fairly quickly. And then we'll talk about what integrated healthcare delivery is, and finally we'll talk about my specific research project. So moving right along, the US spends the most of any OECD country on healthcare as a percentage of GDP, rounding out at about 16.9%, which is nearly double the OECD average. So you might be saying to yourself, well, okay, we spend the most, so our outcomes must be the best. Well, that's not true. We actually have, of these 11 peer nations listed, the worst outcomes in terms of life expectancy at birth, and are significantly below the OECD average by about 2 years, on par with Cuba. So, okay, maybe our outcomes aren't the best, but our quality, that's got to be the best, right? Not so. As you can see, in both 2000 and 2016, the US led these 11 peer countries in amenable deaths per 100,000 of population. And what that statistic means essentially is how many people die due to certain causes that could have been prevented by timely and effective healthcare. So for a lot of cost, we really don't get that much bang for our buck or value. So in comes integrated healthcare. Integrated healthcare delivery can help us promote value by cutting costs and shifting care focus towards outcomes. So costs can be incurred in healthcare through waste, and it's actually estimated that 25% of healthcare costs in the United States are waste. And if you'd like a round number, it's about $1 trillion. And so integrated healthcare delivery can help us mitigate that, but can also shift care towards higher outcomes, thereby increasing value, both by improving quality and reducing costs. So what is integrated healthcare delivery? Well, integrated healthcare delivery, according to the WHO, is the management and delivery of health services such that people receive a continuum of health promotion, disease prevention, diagnosis, treatment, disease management, rehabilitation, palliative care services, all through the different levels and sites of care within the health system and according to their needs throughout the life course. Now, that's very wordy, and so let's distill that down into kind of 4 main points that can really tease out what integrated healthcare delivery is. So integrated healthcare delivery ensures communication between providers. It ensures coordination of care across providers, so between physical therapists and orthopedic surgeons, or dietitians and social workers. And integrated care also ensures that care is continuous over time in between visits. And lastly, integrated healthcare ensures patient-centeredness, so that the patient is treated not only as a member of the care team, but also someone that really dictates what direction care goes. So how is this executed? So integrated healthcare is executed kind of through 5 different types. So one is structural integration, and this can be thought of as physical co-location of providers, in the same building, contractual arrangements between providers of different organizations. And then there's functional integration, which is how those providers who are co-located, how do they work together? The policies and protocols that really streamline coordination and their decision-making. And then there's normative integration, which is essentially a culture that is dedicated to providing care to patients that is integrated. And then there's interpersonal integration, which is that team-based approach that I mentioned earlier between the healthcare providers and the patient, so that care can be delivered effectively, efficiently, and at a high quality. And lastly, there's process integration. Process integration are the organizational activities intended to integrate patient care into a single continuum across time. So let's jump into some examples. Oh, wait, would you look at that? Taco Bell and Pizza Hut in the same building. One could consider that structural integration, but let's get back to healthcare. So in practice, integrated healthcare can really occur in large systems or in small clinics. So at Kaiser Permanente in the VA, for example, in the Mayo Clinic, we have these giant systems that integrate primary care, specialty care, diagnostic imaging services, healthcare payer plans, all into one giant organization. And these are organizations that are very large, attract people across the United States, across the world, really, for their services because of how effective they are and the things that they're able to do in these very integrated, cost-efficient systems. And then integration can also take place in smaller places, like at UT Health Austin's integrated practice units, and as we'll talk about shortly, at the Duke Orthopedic Joint Health Program. And so in these smaller situations, you have clinics that bring together care providers such as orthopedic surgeons, physical therapists, physician's assistants, dietitians, and the like, to really provide a whole range of services to patients in one single clinic visit. And this is a point of integration that has been developing recently, and that UT Health Austin is actually a leader in. So that's kind of in a nutshell what integration is. What did I do? So essentially, in 2 words, I listened. So with my supervisor, Prakash Jayakumar, we went around to 5 different institutions across the country, specifically orthopedic institutions, and just listened to what stakeholders had to say. We listened to clinicians, non-clinical staff, executives, all kinds of people, to hear what they thought about integration and about their process of implementing integration at their clinics. And so these 5 clinics were all at different stages of integration. Some were very condition focused, like UT Health Austin integrated practice units. Some were very procedure focused, like Kaiser Permanente. But we just listened to what everyone had to say, and we tried to distill a key set of themes related to the implementation of integration, and wanted to use that to inform policy across the country and maybe even the world. So let's look at our outputs of the project. So this is kind of a complex slide, but if you look at it from left to right, it's kind of going down this hierarchy tree. So the way we looked at this data, so we interviewed almost 50 people, and we coded essentially what they said into one of 21 options, as you can see by the kind of Christmas colored far right codes, which were either challenges, facilitators, or observations. So 3 there, and then each one, and there were 7 mid-level codes, each of which was related to a specific aspect of integration that I spoke about earlier, whether it be care coordination, continuity of care. And so we had 21 different kind of bottom level nodes that we coded each quote into. So we had between 50 and 250 quotes for each one of those little boxes. And I will expand the last output like that. And this is kind of 1/21th, if you will, of our outputs. We found 5 key themes for this specific thing that we looked at and compared across the 5 institutions what they said about each of these themes. And so the research was very rich, something that I don't think anyone's ever done before. And it's just been a wonderful process. And so a few emergent findings, I mean, there were so many, but 3 that I'd like to just mention briefly, and if there are any questions about it, I'd love to take them. There are financial ramifications to integration, and unfortunately, finances can be a massive barrier to implementing integration. The second is almost every clinic wanted to leverage data in some way, whether it be for predictive segmentation softwares or something like that. Big data is something that they would love to work on in the future. And lastly, clinical leadership and making care a team sport was a very emergent theme that we saw at all these institutions. Having strong leaders that were really dedicated to the cause were very important for implementing integration. And so just some reflections to close out. This really was an incredible project. I'd love to continue with this kind of research as a professional in the future. And to anyone who's maybe a junior or senior doing their thesis next semester, I really encourage you to undergo a project that you really are passionate about and you think you'd like to share with other people. So without further ado, I'd love to take some questions. Special thanks to my supervisor, my second reader, and a research fellow that worked with us. And yeah, so thank you. That's all I've got prepared, but I'd love to take some questions.
Great. All right. Thank you so much, Ray. If you could put your slide off the screen now, so we're back to the multifaceted rectangles. Great. Excellent. Thank you. That was really fascinating. Wow. We already have a question in the chat from Drew Benedict, and it is this: do you think privacy laws on medical information will pose an issue in thinking about integrated healthcare delivery?
Absolutely. So that is a big question. I mean, you have companies like Google who can purchase health data. I forgot which system they purchased it for, but just the word Google and health data really can cause a media outrage. And so, yeah, healthcare privacy is a barrier into having these very large systems that span states, span maybe even countries one day. So that does pose a barrier. But for smaller places like UT Health Austin, it's not as much of an issue that they're facing.
Great. Well, I have a question that's kind of related to this, and it is one relating to the role of software like Epic, which I know a lot of physicians personally who complain mightily about, the cumbersome act of having to deal with that. Mm-hmm. What role do software systems play in either promoting or impeding integrated healthcare delivery?
So they're absolutely a tool for promotion. We actually had an entire code dedicated to assets, technological assets, that kind of thing. So it's something that we track very closely, and something that without fail, every providers at every institution noted as a facilitator to implementing integration. You have all kinds of electronic tools that care providers can use, from the EMRs like Epic, like you mentioned, to other predictive algorithms to segment populations like we have at the Musculoskeletal Institute at UT Health Austin. All kinds of technological assets that are very important for integrating care, because when you think about care integration, one of the key concepts is continuity of care. Which is from one visit to another. Are your records still there? Are they have they been updated? That kind of thing is infinitely easier with effective electronic medical records and the like. So yeah, very good question.
Great, thank you. And we've got a whole bunch of questions in the chat, which has lit up. So I'm going to keep going. So Darong has a question. How does integrative care relate to value-based care? Is it a subset of value-based care?
So that's a great question. That was one of the first questions I asked my supervisor, Prakash Kumar, when we first started researching this back in January. And the answer is integrated healthcare delivery can be considered almost the engine of value-based care. So it really helps value-based care go. So with integrated healthcare delivery, you're trying to maximize the quality you put out, but you're also trying to reduce costs. And the value equation, as they call it, is just that: quality over cost, or outcomes over cost. And so by increasing the numerator and decreasing the denominator, you're increasing the output in value. So yes, it's a very, very related concept, and nice observation, Jerome.
Excellent, excellent. Our next question is from Nima Raman, and it is this: what specific challenges do you foresee for integrated healthcare delivery in rural parts of the U.S.? It's a great question.
Definitely, great question. Rural health is definitely at the top of a lot of people's list of issues. I saw with Biden's new plan that rural health actually might get worse by defunding hospitals and that kind of thing. So something that's very important. But yeah. Pretty much a lot of the technological assets that that these institutions bring to the table might not work as well in rural environments, but they also might provide a lot of access to rural environments. So one of the institutions we looked at was Dartmouth-Hitchcock, and while they're centered in an academic town in New Hampshire, they have clinics all across New Hampshire, all across the Northeast. And they actually have virtual ICUs where they can have intensive care personnel virtually at hospitals from hundreds of miles away to help deliver the best possible care. And that's just a small example. But I think access implementation might be an issue. But once the technological assets are implemented, I think it will increase access tremendously.
Great.
Good question.
Excellent. Excellent. The next question comes from someone named We Love Ray, and it is this. You cited UT Health Austin as a leader. How can other care institutions replicate their success without the structural support of the university framework?
So that's a great question. The UT Health Austin integrated practice units are actually built off of a book called Redefining Healthcare by two of the world's most famous value-based healthcare scholars, Elizabeth Teisberg and Michael Porter. So yeah, UT Health Austin definitely has an advantage in that regard with the structural advantage there. But I really think it comes down to quality improvement in a incremental sense. So not trying to completely change how a certain clinic does their healthcare, but just small changes. Maybe reach out for a partnership between a physical therapist clinic and an orthopedic clinic. You know, small things that aren't trying to change the world, but really trying to change how you do things in a small way, and just continually assess what you've done with that incremental quality improvement, and just continue trying things and not trying to be afraid. But yeah, there's many other ways to answer that question, but I think that's
Sure.
one.
Great, thank you. We also have another question here, and this is a question that asks, are there certain stakeholders who would resist integrated healthcare?
The doctors. Yeah, so a lot of the other frontline providers really like integrated healthcare delivery because they're not in as much debt, or they haven't spent as much time, training, and they don't just want to do surgery, that kind of thing. So there's a lot of different competing interests, but for our research specifically, it's very hard to mobilize the doctors into integrated techniques because they, at the end of the day, benefit from a fee-for-service model that doesn't incentivize value over volume of care. So that's one stakeholder. Of the institutions we surveyed, they were all academic learning institutions. So doctors who aren't in private practice, who aren't as concerned about making money because they're probably salaried. So that doesn't come up as much, but definitely the doctors in private practice might resist this.
Indeed.
And the EMR companies, because they make a boatload from having proprietary algorithms.
Indeed. Right. Okay. Thank you. That was really fascinating. So the next question comes from Prakash Jayakumar, and it is this. For traditional fee-for-service healthcare systems to make a shift toward high-value integrated care, are there any particular types of the integrated care taxonomy you stated that they should or could start at the outset? And then, that is to say, structural, functional, interpersonal, normative process. What could they start with tomorrow? Do you have any examples?
Unfortunately, my Wi-Fi cut out a little bit there. Do you mind reading the second half of the question?
Not a problem.
I do appreciate the question, PJ, but I will try to answer it. Like, do you mind saying it one more time?
Okay, no problem. So I will start. Okay, I'll just read it again. For traditional fee-for-service healthcare systems to make a shift toward high-value integrated care, are there any particular types of the integrated care taxonomy you stated that they should or could start with at the outset? That is to say, structural, functional, interpersonal, normative process. What could they start with tomorrow? Do you have any examples?
Definitely. I'm glad it came through clearly that time. Definitely. So the organizational and process sides won't be something they can do tomorrow. It'll have to be something on the social side, which would be either normative or interpersonal integration. And I would say interpersonal integration. So what that means is teamwork, emphasizing, when they go to the hospital, that they might be a part owner and that they might have operating privileges that is in no way related to their private practice clinic. When they go there and work with their surgical team, they emphasize how important it is to be a team caring for this patient, realizing the system level impact every single suture costs the system, and how important it is for the patient to have the floor in care delivery and that kind of thing. So I'd say the interpersonal teamwork side is something that tomorrow I would love for every orthopedic surgeon in America to go emphasize.
Yes, absolutely. That is really, really great to be thinking about that as something that could happen tomorrow, for sure. Well, I wanted to ask if anyone has any other questions for Ray. Feel free to put them in the chat. But I think that we are, our time is winding down. So I will just use this last couple minutes to thank all of our wonderful, wonderful thesis students for such fascinating, timely, and really productive presentations, and for your research, and just to offer such a big applause of congratulations to each of you. Really fantastic. And I wish you all the best. And thanks to the supervisors and second readers who also mentored each of you as well. So thank you so much, everyone, for joining us. And a big shout out to Christine and the staff at the Thompson Center for really being so amazing and helping us as well. So thanks to everyone. It's been great. And I hope you have a wonderful evening. Take care and bye, everyone. Thanks.